Okay, well, welcome everyone, and thank you for joining us this morning. Just a few housekeeping items. We'll get started today. Today's session is going to be an hour long, and we'll have some Q&A at the end. So feel free to put your questions in the chat. If you would like to put a question in anonymously, make sure that you just put it into Lindsay Hanlon, and we'll handle that accordingly. Please note that you will get CME credit for this, and the link will be provided at the end of the webinar. Any resources mentioned at today during the webinar, you will also be given those resources at the end of the webinar. So the presenter also we wanted to make sure that you knew that the webinar is being recorded today, and it will be available for future viewing for those who weren't able to make it today. The presenters have no financial relationships or conflicts to disclose today, and the webinar was approved for one AMA PRA category for one credit. So with that, I'm pleased to announce or introduce today's presenters, Dr. Sarah Chada, who is an OBGYN, has been practicing in Lincoln since 2004. Dr. Darla Eisenhower, who is also an OBGYN, who has been practicing in Lincoln since 2008. And Dr. Sean Jones-Jopes, who's primary care pediatrician and president of Complete Children's Health, PC, in Lincoln, Nebraska, where she started practicing 20 years ago this past August. One of Dr. Jones-Jopes' many professional interests in physician wellness, which is why she knows the topic of perimenopause and menopause is so important and brought this topic forward to discuss today.
Okay.
Dr. Jones-Jopes, would you mind speaking a little bit about this topic and how it became important for you as a female physician?
Yeah, well, I went to medical school in the late 1900s, graduated in 2000, about 2 years before the Women's Health Initiative results came out. So I was in residency when I remember actually seeing on the news more than I heard as a pediatric resident. We probably shouldn't be putting women on hormone replacement. It's going to cause them to have cancer. We thought it was going to lower their risk of heart disease, but it actually increased their risk of heart disease. And that's really all the education I got about menopause. When I was in medical school, I really learned your ovaries fail, your periods stop, and your risk of heart disease goes up to equal a man. So that was kind of all I learned. And in comparison to what I learned even in the 80s in elementary school about puberty, I knew less as a physician about menopause than I did as a teenager about puberty. So it really wasn't until the last 10 years, as a woman in my 40s, now 50, that I started to recognize that, gosh, this is a big change in people's lives, but I didn't really understand that it was really related to my reproductive system and menopause. I really just thought it was aging. It was during the pandemic that I started to notice a lot of changes all at once, which was kind of surprising. I just thought over time I would gradually, gracefully age. But, my hair changed, my skin changed. Medical issues that had been minor before, like intermittent migraines, got much, much worse. My libido tanked. I started having more anxiety and mood issues, all at the same time as most of us in our careers are kind of reaching the height of our careers. We've got established practices. Maybe we're taking on some administrative and management roles. And maybe we've had kids and now they're teenagers and they're in high school and they need us. And we're dealing with a lot of things that I don't know that we even talk about as women. And so luckily, I have a great internist, Dr. Deanna Patera, and she and I started talking, and I got the education that I needed. But I really recognized that this is something that I don't think a lot of women talk about or that we as physicians, unless this is our specialty, even know much about. And there's even some physicians out there that don't know much about menopause or how they can help women through it. And if they're going to a practitioner who isn't educated and isn't up to date, they may not have options available to them. So, as a middle-aged, proudly middle-aged female physician, I thought this is something that maybe we should all talk about and educate ourselves about, and then we can pass the word along and help our colleagues and even our patients, or in my case, my patients' parents. So I'll let Dr. Eisenhower and Dr. Kada take it from there because they really are the experts.
Yes, thank you, Dr. Jones-Jobs. That's a perfect intro for them. And so appreciate you bringing up the important topic and getting us to launch a webinar on this. So thank you. And I'll turn it over to the experts. And if you could give us a kind of rundown on menopause and perimenopause 101.
Yeah, so first of all, the definitions. And so menopause is defined as a year without period. It's when you've had the permanent cessation of menstruation after the loss of ovarian activity. Perimenopause or the menopause transition are the years leading up to menopause. Um, Perimenopause is kind of like puberty in reverse. The ovaries are figuring out how to function and cycle. During perimenopause, the ovaries aren't functioning as well, and some months might be fine. Other months might be less, they might be less responsive to and have more lows in estrogen followed by surges in FSH, and therefore surges in estrogen and testosterone. Because in perimenopause, the ovarian hormone levels are fluctuating, there's no perfect blood test that detects perimenopause or menopause, especially in situations where women have had a hysterectomy or an endometrial ablation that has stopped their periods. It sometimes makes it trickier to figure out when exactly are they in menopause. The symptoms can overlap and exacerbate symptoms due to other causes. And then risk factors for increased symptoms of menopause include obesity, smoking, reduced physical activity, African American ethnicity, and then genetic variants, which usually I just ask people what their maternal history was like, but they found that variants in tachykinin receptor 3, which is involved in temperature regulation, can cause more severe symptoms. Darla's going to talk about some of those symptoms.
Yeah, thanks, Sarah. So our focus this morning is mostly on natural menopause because those women undergoing hysterectomy or their ovaries being surgically removed or chemotherapy, they're going to maybe experience a little bit different onset of their symptoms, a little more abrupt. For those experiencing natural menopause, there is no one size fits all. It's not like there's this universal menopausal syndrome. And so that makes it challenging because every woman is going to experience it in a little bit different way. Kind of the common symptoms everybody knows and talks about are the hot flashes, night sweats, and vaginal dryness. But other common but not as talked about symptoms can include, insomnia, depressed mood changes, sometimes increased menstrual migraines, particularly in the early phases of perimenopause. And then you also have some less common symptoms where women might experience kind of your mental fog, the difficulty with sexual function, dry eyes, hair loss, UTI changes, body composition changes, kind of where we store our fat or extra, which can also lead to kind of that roller coaster of up and down that a lot of women experience, particularly through perimenopause. We also, in newer research, is looking at the microbiome, which I think they're looking at that in lots of areas. And so the bacteria that live in our bodies and on our body changes with our hormone changes. And so then you have GI changes with that, and sometimes a change in just odor and just how we are, which also can create a little bit of anxiety for women. As far as age range and what we're talking about with that, the average age of menopause is 51 to 52, depending on what source you want to quote. Most women experience natural menopause sometime between age 45 and 55 is kind of the range. Symptoms can start up to 10 years prior to that last menstrual cycle. And so it's kind of a wide range. Some women experience those symptoms that full 10 years, some of them only have 3 to 5 years of more intense symptoms, which makes it a little bit hard to know where you are in that process. There are some women that, again, most within a couple of years of their period stopping, a lot of these symptoms will actually improve and resolve. But there's a few people that'll maybe have hot flashes for the next 30 years, but usually not as intense or as frequent as initially.
So that's kind of the symptoms, the age ranges, and then we were going to talk about like where should you start, what should you expect at your initial appointment. So typically the diagnosis is made based on clinical symptoms and period history, because like Dr. Eisenhower said, it's not a one size fits all experience. And this can mean ruling out other causes of a woman's symptoms. It's determined partly based on age and also include checking for pregnancy, hormone imbalances involving other glands in the body, such as testing thyroid, prolactin, sometimes androgen levels, along with FSH. FSH could be normal or it could be in the postmenopausal range. And then ovarian hormone levels can be unhelpful because of their fluctuations during perimenopause or the menopausal transition. An initial visit would include a menstrual history, a thorough review of symptoms, and hormone testing is detailed. I also ask patients what their goals are, including what their main symptoms are that they want addressed. Treating more women during this phase of life includes more personalized care. Women will want to know if they still need contraception. Other women might have symptoms affecting their quality of life. And part of determining treatment options, along with making sure other possible causes of symptoms are addressed, can include assessing breast cancer and heart disease risks. This will help determine what are the best treatment options for patients.
So when we talk about treatment, one of the first things to think about is, are they a candidate for hormone replacement? Can we just supplement those hormones that are kind of going up and down or decreasing that might help their symptoms? A lot of the medications are aiming at your first or initial symptoms of the hot flashes, night sweats, vaginal dryness, although we can see some improvement in some of the other symptoms women experience, particularly sleep, and then the mental function that goes along with that lack of sleep that happens. So hormone replacement therapy, looking at risk factors and is it right for them? If they still have a uterus, it's going to be a combination of estrogen and progesterone, where you need the progesterone for the uterine side and uterine protection. If they no longer have a uterus, then you can look at estrogen alone. That's going to replace a lot of what they're missing and or supplementing to help with symptom relief. These can be conjugated estrogens. They can be bioidentical or plant-based estrogens in standard dose equivalents. There's lots of ways to get estrogen, whether that's oral pills, that can be gels and sprays and patches you wear on your skin, depending on what fits in your lifestyle, which is nice. Progesterone is a little more challenging to get in and get in consistently, but estrogen has a lot of options available. Now we have VOSAs, so when those HRT or those hormones are not the right fit, so someone with breast cancer or history of blood clots, health contraindications to using estrogen, then you have to look outside that estrogen. Veoza is a newer medication that works on the hypothalamus to block the neurokinin 3, which then will decrease hot flashes and night sweats. So for those women that can't take estrogen, that is a good alternative and is almost equivalent in dropping hot flashes and night sweats for women. We have other classes of medications, so SSRIs and SNRIs are also available and have been shown to blunt some hot flashes and night sweats in women. Also can help with some of those mood changes that happen during the perimenopausal transition also. Oxybutynin, which is used to reduce urinary frequency, can also blunt hot flashes and night sweats. The downside is it dries you out, just like a lack of estrogen dries you out. So the dry eyes and some of those symptoms might be a little bit worse with that. So again, depending on goals and what women are looking for, to tailor the options based on other symptoms. Gabapentin, particularly for nighttime and the difficulty sleeping from those night sweats, gabapentin can blunt those and help with nighttime sleep, which again can improve mental function because you're getting better rest at night. When the Systemic symptoms are less, and later on, postmenopausally, vaginal dryness seems to be the symptom that kind of lasts the longest and throughout women's lives postmenopause. And so there are estrogen treatments just to the vaginal tissue and vulvar tissue, which most patients, there is an option for them, even when they've had cancer or DVT, and they don't necessarily need any progesterone to protect their uterus with these tiny amounts of estrogen that act locally within the vagina itself.
I was going to talk about bioidentical hormones next. Many compounding pharmacies use the phrase bioidentical hormone as a marketing term that implies that their preparations are natural and safer or more effective than US FDA approved menopausal medicines. But FDA approved menopausal medicines may include bioidentical hormones as well as synthetic hormone preparations. Compounded hormones don't have the evidence to support their safety and effectiveness. And according to the American College of OB-GYNs that sets the guidelines for OB-GYNs and then the Endocrine Society, they shouldn't be routinely prescribed. They can be appropriate in some situations. For example, when a treatment isn't commercially available or when different ingredients are needed because of patient intolerances, such as they can't swallow a pill or they have a peanut allergy. There are also some non-MD clinics that are popping up that are popular in our area that market themselves as hormone specialists. I think it's important for us to know that the doctors that are trained specifically in menopause include OB-GYNs, endocrinologists, and many primary care doctors. Some of the hormone specialty clinics are offering hormone testing and compounded hormone treatments that aren't supported by our organizing guidelines that we follow in OB. And then the studies on compounded hormones are inadequate to assess the risk of breast cancer and cardiovascular disease. So I think it goes back to kind of taking a personalized approach. You have to evaluate, what symptoms the patient wants treated, what her, are her other medical conditions like her thyroid or sleep apnea, are those things being addressed and treated correctly? And also, what is her risk of breast cancer, heart disease? Are hormones the right option, or should we look at other possible options, as Darla mentioned?
Now, as far as resources out there, obviously your own gynecologist can talk to you about the different options. Endocrinologists also can. The North American Medical or Menopause Society is a good resource. They have lots of podcasts, both patient-facing and physician-facing information. ACOG, or the American College of OB-GYNs, has both physician and patient-facing information about menopause. There's an article that Lindsay will have and send out to you that's from the Endocrinology Society, kind of taking you through the steps of looking at menopause and how to go about selecting a treatment option, or even talking to patients about their options, which we'll give to you. Lifestyle is something we can't ignore, although some of the lifestyle and vitamin options out there haven't been shown to have large impact on menopausal symptoms specifically. They have been on overall health and well-being. And so looking at diet, exercise, sleep, I think in our 20s and 30s, our bodies, or at least mine, has been pretty forgiving to me. I kind of abused it and didn't exercise, didn't sleep quite like getting through work and life. And now in my 40s, almost end of my 40s, I'm realizing that my body's not as forgiving. It's more important for me to build in healthy lifestyle, and it does have a true impact on how I feel from day to day, building my muscle with exercise, eating well, and making sure I get sleep or time to recover for those nights that I don't get sleep because of my job. So Harvard has a paving series, and there is a paving for menopause, paving for breast cancer and stroke surviving. And that's focusing on that lifestyle piece that can also help with how we feel, thinking of us as the whole person, including social connection and variety and mental stimulation to help with aging along with menopause.
Sorry, I needed to unmute myself. Okay, so as many people wonder, is there a light at the end of the tunnel? And can you talk about that a little bit?
Sure. So, in my experience in talking to women about this transitional time, starting in the early 40s, I kind of mentioned that they might be starting to notice some changes. The ovaries are less predictable in their function. And so, some months there may be a bunch of hormone that increase their PMS symptoms, their mood changes, menstrual migraines, and then other months a drop in those hormones where they have kind of the cyclic hot flashes and night sweats, where it's only about a week out of the month that they notice those symptoms. Then late 40s, they're going to notice a little more intense symptoms. The ovaries are shutting down a little bit more. And so those hot flashes, night sweats, the difficulty sleeping kind of play a role in that age range a little bit more. And this cycle starts spacing out and getting lighter as a general theme. As menopause happens in the early 50s, then there's about 1 to 2 years of kind of those more intense symptoms of the hot flashes, night sweats, the difficulty sleeping, mental fog, kind of those big things. And then after that, you start seeing a reduction in those symptoms. And so most women, even if they had sexual function changes during the transition, that roller coaster, once their body can adjust to that new normal, then a lot of these symptoms get better. You do adjust and you do have return of a lot of the function that you felt like was all over the place or not as good later on.
If I
Yeah,
recall,
so most women, about 90% of women will get some resolution by the time they hit 60.
woohoo!
Yeah,
Hallelujah.
Almost there.
It does happen.
yeah.
Um, so you had some wonderful graphs and some other things to show us, if I recall. Yes.
Yeah. I think this just kind of summarizes all the prescription type options that are available right now, that are FDA approved. And then the slide right before that, this one, I think this is a good one. It compares the alternatives. It has Magestrol, and medroxyprogesterone acetate is the one at the bottom. So those are progesterone. So these are alternatives to estrogen for treating hot flashes. And I think, to me, the important thing is, if you see like 5 down, is the placebo effect. In a lot of the studies, the placebo has effectiveness at treating hot flashes up to 50% effective, which, when you look at like black cohosh and soy and vitamin E, I mean, those aren't as effective. Those aren't quite as effective, or right around the efficacy of a placebo effect, which I think is important for people to understand. So
I think something we're seeing is, especially with social media and different things promoting the over-the-counter non-prescription options, we're seeing that everywhere, and it makes it seem like, wow, this is the new thing that's really going to make a big difference. But then when you actually look at what's been studied, it's really not that much different than placebo effect on most of those that they're promoting and pushing. So that makes it hard for women to weed through all the information that's out there.
Great. Thank you guys so much. We do have a few questions that have come in that if we could go through some of those. One that came in, what about the use of testosterone in perimenopause and menopause? Can you speak a little bit to that?
As far as what's been studied, postmenopausal women with low libido is where testosterone has been shown to have the true benefit is. And there's a patch that's actually not available in the US that was studied that shows the best benefit. And so in the US, the hard part is figuring out, well, how do we use the doses we have available to mimic what that patch was able to achieve in the studies. But it was postmenopausal women and improved sexual function.
So I think one of the options that we have, like for vaginal dryness, there's DHEA, which is a precursor to testosterone. If you want to prescribe testosterone itself, that's where you have to go through a compounding pharmacy. And in that situation, ACOG that sets our guidelines says testosterone compounded could be an acceptable option, but you have to counsel women on the risks and benefits of compounded hormonal therapies. They are against testosterone pellets, and that's because, and so there are some practitioners in town that are placing testosterone pellets, and those are dissolvable testosterone pellets that are compounded at a pharmacy that they kind of inject into the buttocks. And because there's variable absorption and it's not something you can remove, are kind of their justifications for going against the pellets. I had a woman that was prescribed testosterone treatment at a rural health group, and she had a history of a DVT and a PE in her 20s, and they put testosterone pellets in her. Her family doctor sent her to me to see if it was safe for her to continue. I think it's important for people to understand that, that's one of the contraindications to hormone therapy. One of the absolute contraindications is DVT, blood clots, thrombophilia, and testosterone's aromatized to estrogen when you get an excess amount. So I think
you have to be careful.
You have to be careful. Mm-hmm. I think then they put her on tamoxifen. The only reason I can think of is to try to block the aromatization of estrogen in the breast, but tamoxifen is also a thrombophilic medication. So just important to make sure people are getting safe care.
And just to continue this conversation, we did have another comment. I have a patient coming in wanting hormone testing, which isn't necessarily medically indicated. How would you proceed talking with that patient to have them avoid going to some of those pop-up clinics that you discussed?
I don't know that you can necessarily stop them from going. I usually back up and talk to the patient about what their ovaries are actually doing and why that monthly testing or regular testing doesn't end up helping them. And it doesn't necessarily guide management either. Your ovaries, and again, perimenopause is when we see this the most. It's because it's the up and down. And if you look at the graphs of this, it is an up and down line of estrogen through perimenopause, where you have some months that it's flooding your system with a bunch of hormone and other months it's not. And so when you get your hormones tested, it's just telling you what your hormones are doing right then. It isn't predicting where are they going to be next week, where are they going to be next month. And that's what's challenging is talking through, well, what is this lab really telling me? And does it predict anything that your ovaries are going to do in the future? And talking that through with patients on how this helps versus doesn't help. The other thing about estrogen, there's a wide range of normal. And just because your estrogen's in the normal range doesn't mean you're not experiencing symptoms, because it may be different for you and your body's responding to the change. And so it doesn't mean that you don't need or treatment for those symptoms that you're having. And so it's really focusing on what is your symptom, which symptoms are impacting your life, and how do we make that better for you, regardless of what your hormones are doing. We're trying to treat how you're feeling.
Yeah, and I think also there isn't a certain therapeutic level that you're aiming for. The normal range for estrogen is huge. What's normal for estrogen after menopause is for estrogen to be zip.
Right. Low.
And so, I'll have women come in and say, well, I'm 60, I went and got my hormone levels checked and I have no estrogen. I'm like, well,
Yeah.
that makes a lot of sense. You shouldn't have any estrogen right now.
Mhm.
So, there isn't a certain, like Darla said, there isn't a certain dose that makes everybody feel good. I mean, we're really tailoring it to the symptoms. So you're not looking for a therapeutic dose. You're looking for what's the dose that will resolve the symptoms you're aiming to resolve, that's safe for the patient.
And it can be frustrating. I mean, patients get frustrated because it is a little trial and error because everyone is unique. And this is one time they really are really unique. And there isn't one dose or one thing that's going to work for everybody and or one progestin that's going to work for everybody. And so it does take a little trial and error or testing, if you will, we're scientists, to figure out what is the right fit for each person. And yeah, that can be frustrating for patients, but treating a number isn't really helpful. And talking that through of, hey, an estrogen of 30 doesn't mean you're going to have these symptoms, or an estrogen of 100. We aren't going to be able to use a number to tell you how you're going to feel.
I think it's also important to explain to them that salivary testing is not reliable. There's still saliva testing going on, and it doesn't necessarily reflect blood levels of the hormones. So,
I believe you touched on it earlier, but there was a question that came in earlier. Do women need contraception during their menopause period?
during their transition, they do. During perimenopause. And that's where, especially in women that have had, for example, an endometrial ablation, where they aren't having periods and you don't have a hormone test to tell you exactly where they're at in their transition, can be challenging. But they'll need it until you've been a year without periods. And you do that based on age and clinical judgment.
We have another one that just came in the chat. I have a patient, age 50, experiencing menopause symptoms, hot flashes, insomnia, and new onset anxiety. She has no personal contraindications for HRT, but the mother passed away from ovarian cancer due to other FH cancers, thyroid, stomach. I did refer her to genetics. We discussed gabapentin versus SSRI, SNRI. I do wonder, though, could she be a candidate for hormones?
Sounds like, I mean, if it's ovarian cancer, as far as a female cancer, it's her only family history, it doesn't sound like there's a contraindication in the information that's been provided. So I think estrogen or hormone replacement therapy would be an option.
So the absolute contraindication for cancer would be if they had breast or uterine cancer.
Any advice for patients to find an evidence-based OBGYN or PCP to help them? For example, have seen some women on pellets prescribed by an OBGYN.
That's challenging.
That's challenging because they're, to tell you how each OBGYN practice is. We can just tell you that, the North American Menopause Society and ACOG, they don't support some of that. And so looking for providers that follow the recommendations of those two societies are probably our best bet, but I don't necessarily have or know a list of providers that follow that or not.
Can you
I
speak?
agree with that.
Oh, sorry. One that had come in earlier, can you speak a bit on managing the brain fog, or what are some tips to help when working as a physician too? And I'll open that up to the whole panel.
So brain fog, and with some of the less common symptoms, I think we have to remember that usually those are mild. So as long as your brain fog is mild, yes, it's probably perimenopause. If you have more severe cognitive changes, then don't chalk everything up to menopause. And that's true of joint pain and muscle aches. We also have to remember that there are other medical conditions that can lead to these. So I would say as long as those symptoms are mild, yes, they could be menopause or perimenopause. But if they're more intense, then rule out other things too. again, as I said a little bit earlier, I think our mental function is impacted with by a lot of things, hormones being one of them, our sleep quality being another big one. And so I think we have to take a little time to set up our lives to be successful in getting sleep, your 7 to 9 hours. Most people need 7 to 9 hours of sleep. And if we cheat that, we're going to see some slowing of our mental function related to that. I think, physical activity has been shown to improve mental function. And so increasing your physical activity, particularly your muscle building activity, can be really helpful. I think connecting with others and trying new things can also be helpful at this stage in life, and decreasing stress. Anytime we're under stress consistently, we're not going to be as great from a mental function standpoint.
And I think also that's where making sure there aren't other conditions, including thyroid, anemia, blood sugar fluctuations. I mean, there's so many things that can impact how our brains function.
Another question we had here, do you have some recommendations for late publications for friends or relatives?
There are resources for patients on the ACOG website, and also some on the North American Menopause Society website. And then you put the paving for...
Yeah, the Paving for Menopause is a patient-facing, it's a book that's out there. It's designed for patients. So that's an option too.
And I just dropped the link to that book in the chat as well. Any other questions from the group? Any other comments, tips, or tricks for others on the call as well that you'd want to share?
I would just add that as we get older, our tolerance to caffeine can change. And it's really common to have a caffeine dump in the afternoon if you are using a lot of caffeine in the morning. And so if you find yourself with a late afternoon, 3, 4 o'clock, sleepies, foggies, whatever you call it, and it's predictable in the afternoon, you might really pay attention to your caffeine intake in the mornings. And particularly as it relates to all morning use, because caffeine is blocking a chemical that allows you to induct your sleep. And so it's blocking all of that sleep hormone. When the caffeine wears off about 3 or 4 o'clock in the afternoon, you get a flood of that sleepiness hormone, that sleep pressure. And so then you get really sleepy at 3 or 4 o'clock in the afternoon, and you kind of wonder why that is. Well, if you're predictably getting that at 3 or 4 o'clock, check how much caffeine you're taking in, 8 a.m. to noon or 5 a.m. to noon, whatever it is. And if you can work on that a little bit, your 3 or 4 o'clock dump might change a little bit.
So, Joanne, the answer is not less caffeine in the morning, it's more caffeine at 3 o'clock.
I would say try to moderate your caffeine and switch to, half calf. But yes, people do, go ahead and do the caffeine all the way through the evening. But I'll tell you, the literature on that is really, and the blood testing on that is really quite interesting if you look at that and its impacts on sleep. And then, we just become a little bit more sensitive after we lose our estrogen.
I think another area that a lot of women struggle with is their body composition changing. Estrogen keeps weight gain on your hips and thighs. And when you start having less estrogen and in your late 40s, you start noticing that you get more weight gain in your midsection. And that can be a real shocker and uncomfortable body change for a lot of women. The downside is estrogen replacement or hormone replacement doesn't necessarily change weight gain. It'll change distribution a little bit of weight, which can be a challenging conversation because it's kind of this age and menopause all at the same time that's both things are impacting that body composition change. So I think a lot of women come in kind of with that complaint of, I have a belly now and I never had one before. What is going wrong with me?
I think it's a good wake up call. I heard a podcast where a physician said the warranty runs out at 40. And I feel like at 50, it really accelerates. Like, and this is the time of life where you really have to decide how you're going to age. Are you going to try to eat healthy, get your sleep, do all those things that you always say you should do? Or are you going to finally, try to live that kind of healthier lifestyle to try to age well?
We did have
hard.
Yeah, really hard.
I mean,
I was going to say for me, it was even just putting a name on it and saying, okay, this is normal. This is a part of being a woman. This is a part of turning 50. And my ovaries are not doing for me what they used to. And I'm going to give myself some grace. And I think we all have to recognize that we've fought really hard to get where we're at. And we deserve to give ourselves a break. And so, if you need a break in the middle of the day, take a break in the middle of the day. If you need to turn the light off and do some deep breathing, turn the light off and do some deep breathing, and erase all those external inputs and kind of reset. And that's okay. And I think if we all give each other some grace and ourselves some grace, we're not residents anymore running around the hospital, having to respond to pagers. So, but you have to do it for yourself, and you have to recognize that in the long run, it's going to make you more efficient and more healthy. And that really does help with that brain fog, with the memory, even just putting a name on it. Oh, I can't remember her name, but that's okay. I'll remember it in an hour. It'll be fine. And that makes a big difference.
And I think that not knowing that you're not alone, that yes, you're on a roller coaster and it's super uncomfortable, but a lot of women are on that roller coaster with you, and it is not forever. There is a light at the end of the tunnel. That roller coaster will even out and straighten out a little bit and be a little more manageable. I think, mid 40s and late 40s is really challenging with those ups and downs.
There was a good article that we had to review for our board certification this year about brain function. And it said that you see a decrease in perimenopause, but then your brain recovers afterwards and gets back to normal. So maybe like Dr. Jones-Jobe said, have more grace with yourself and just hold on.
We did have one other comment or question in the chat. How are you transitioning from OCP to HRT?
I guess for most women who are otherwise healthy, I'll leave them on OCPs until that average age of menopause, around age 51. And then we'll talk about transitioning to a cyclic hormone replacement therapy and using condoms or some other form of contraception as a backup initially, is typically how I do it. If you go straight to HRT, continuous dosing, a lot of times you'll have random bleeding and breakthrough bleeding. So you sometimes have to do it cyclic for a while before you transition to more continuous.
I'll talk to patients that are on the pill about switching to a progesterone only pill. That's one of the things I'll do too. Because if they quit having periods on the progesterone pill, then I feel like, okay, they're not making estrogen anymore. So I think in some situations, that's a good alternative for them as well.
I really like women who have done the progesterone IUDs because that'll carry them kind of through that time frame, and we can still replace some hormone and help with symptoms without necessarily having to worry about contraception. But that's not for everybody either, but it is helpful.
Any other questions, comments from the participants on the call today? You can continue to send those in to us. We can always answer those following the call. I did want to just touch on a couple of things, but certainly continue to jump in if you've got other thoughts. As a reminder, you do have a resource available to you, LifeBridge Nebraska being one of them. LifeBridge offers free and confidential peer-to-peer physician coaching to all Nebraska licensed physicians. So you can call the confidential line that's listed here and you can be paired with a coach. Navigating dealing with menopause could be one of them. We've got a bunch of great coaches. I'd like to acknowledge the coaches that we do have on the call today. Dr. Schaefer has been moderating. She's our medical director here, has a lot of knowledge. We've got Dr. Mark Davis, an OBGYN on as well, and Dr. Michelle Sell, who's family practice, that's here as well. So reach out, chump on our website. Their information's on there as well. Also, following the passage of legislation in 2023, LifeBridge is the only program in the state that's protected under statute. Physicians are protected against discovery of participation in the program, and they're not obligated to disclose their involvement to any healthcare facility, hospital, medical staff personnel, accreditation organization, health insurer, or any other entity. And then finally, I want to reiterate that this program currently remains at no cost to the generosity of our sustainability partners. And so I want to throw that up here real quick and thank them again for ensuring that this service remains available. Again, thank you guys for joining, Dr. Eisenhower, Dr. Chada. Thank you, Dr. Jones-Jopes, for bringing this topic forward. I think we had a lot of really good discussion. We will share out all of these slides. This video or webinar will be recorded. We'll post that as well. And as I mentioned, continue to send in any questions that you might have, and any of our presenters or our coaches are happy to answer and reach out. But I'll leave it open if there's any other final comments, but wanted to thank you guys again for joining us.
Thank you so much.
Thank you all.